Good evening, all, and thank you for joining this is basic CLL. And today is very different from over the last 3 years we've been doing it. So first session will be chaired by Professor George Follows, and we'll hear Talha Munir talking about clinical trials. And the second session will be really exciting, and we're trying to recreate virtual MDT with very unusual CLL cases. So without wasting too much time, I'll hand over to George for the first speaker.
Tonight we are cutting edge with Tal. I'm delighted to introduce Tal, who, as you know, leads the CLL research program in Leeds, has worked very closely with Pete Hillman over all these years, and Tal has been was the first author on the FLAIR trial published in the New England Journal of Medicine, an enormous asset to have in the UK. So Tal, if I can invite you up onto the virtual stage.
Thank you very much, George. So I've been asked to cover the design and conduct of clinical trials in UK. I'll just give you a flavor of what we have been doing over the last decade or so in terms of the CLL clinical trials, which is where my interest is really. So I think one of the important things in CLL, and as we discussed, we might have discussed in the past sessions as well, is that one of the challenges in the designing a CLL trial is that the standard of care is very rapidly evolving. So I've just put down some years where the frontline therapy was chlorambucil monotherapy in 2010, and we had FCR and bendamustine rituximab as our main standard of treatment. By 2013, we were using chlorambucil with an anti-CD20 antibody. And it didn't take us long before 2015 when ibrutinib was licensed for use in CLL. And you can see by 2018, we have got fixed duration therapy in the form of venetoclax and obinutuzumab, and then came along acalabrutinib with obinutuzumab, with or without obinutuzumab. And now in 2023, we've got venetoclax and ibrutinib along with zanubrutinib. So the problem that we've got in CLL is that when we are constructing a trial at one time point, we are using the standard of care, and all of our stats and everything else is based on the fact that we are using that standard of care as our baseline to see whether there's going to be a difference in outcome with the with the experimental arm of the study. And in CLL, the problem has been really that the standard of care keeps on shifting all the time, and the trials are finding it difficult to catch up with that situation. And the other problem is, as you can understand, is that we have got rapidly evolving novel therapies. There are single agents which are given as continuous therapy, but then there are combinations. We have got different mechanism of actions and endpoints in various trials. So when we are trying to do cross-trial comparisons, that is very difficult to do. Simply because a simple example would be that in a lot of academic trials, the CT scans are done sparingly, which is the right thing to do, in my opinion. But in a lot of pharma-driven trials, the main focus is looking at progressions from the CT scan point of view. And as a result of that, when you're comparing the different trials, you might get different outcomes. And then there is difference in short and long-term toxicity. So lots of questions that need to be evolved. I think the important thing that I want to get across to any future researcher is that we have to learn from our clinical trials. And the most important thing that we've learned from CLL is that understanding the biology of the disease is extremely important. And that biology has informed us to choose the right treatment. And once we have been successful in that, then we're going back onto the biology and then talking about the treatment. And a simple example would be that we've used ibrutinib, acalabrutinib, zanubrutinib, and we know that these are blocking the BTK at one point, which is the cysteine of 481. But now we've got other molecules which are blocking the BTK at different places. And the biology started with exploration of BTK, and it becomes the standard of treatment. And now we're working our way around the same concept. In UK CLL trials, what we tried to do, and this has been focused for a long time, is that we want to choose effective therapy regardless of age and comorbidity. So we want to do the trials which actually reflect the real world evidence, and then again the disease subgroup we want to include majority of the patients and do the trials in both frontline and relapse refractory space. And we want to use tolerable therapy so that we can give look at the short-term toxicity, but then the long-term toxicity as well. And one of the main focus that we had for a long time, and George kindly alluded to that, is to look at the duration of therapy and whether we can individualize therapy based on the response with the individual patient. And essentially, one of the questions, the big questions in CLL is that we've got such good treatments. Do we want to cure the disease or eradicate the disease? And how can we not harm patients by stopping too soon or giving too much treatment to our patients? So all of these questions have been the cornerstone for constructed different trials. And this is what I have been part of, and it was my absolute pleasure to work with Pete to integrate the phase 1/2 and phase 3 program that we wanted to do. And what we wanted to use was a TAP Bloodwise platform. And we first of all looked at the relapse refractory patients. And what we were able to do is do very accelerated and streamlined trials, so recruiting patients over 6 to 12 months, and then doing the biology and looking at correlative science and see what combinations make sense, and then trying to use those combinations into the phase 3 program for the frontline patients. And we used this technique, which is the adaptive trial design. So we accommodate the changing standard of therapy, and then also changing the endpoints of the therapy and trial. And this is a well-known way now to conduct the trials, especially in chronic diseases, and also adapting by biology of the disease. And I will give you some examples during the talk. And one of the other cornerstones of the UK CLL trial portfolio has been the biobanking. So the biobank is where we are storing our samples, patient samples kindly. Patients are donating it into the biobank. What it helps us to do is to collect the samples in real time and allow us to use these samples for a later research program. So we store the sample, and then for individual trial, we get different applications from different researchers, and we are able to then allocate these samples to the patient. So this is in Liverpool, and if anybody has got any project that could be submitted, Melanie is the right person to ask that question. But once the submission comes through, she will send it to the trial management group, and we will have a look on that and also say whether this, the samples could be released to the researcher. And that has been quite useful in terms of getting good research papers out as well. So I'm just going to give you a flavor of what we've done in UK in the last 10 years or so. So I talked about the individual drugs. So ibrutinib was one of the first BTK inhibitors that came along around 12 years now. I think 2011-12 was the first patient who was treated with ibrutinib. And at that time, we went to the funders, so which was the Leukemia and Lymphoma Research at that point. And we looked at approval for two cohorts. One was the treatment naive cohort, and second was the relapsed refractory cohort. So very small study of 40 patients, looking at the question whether ibrutinib is effective in these patients, whether we're seeing any toxicity in these patients, but also doing a lot of correlative work, looking at the flow. We did the phos flow in all patients at that point, calcium flux, did some epigenetic work as well as genomics, and looking at the resistant mechanisms in these patients. So this is just for people who are listening, these kind of small trials actually allow you to do a lot of correlative science, which helps us to design the next part of the project. And the important thing was that we recruited these patients in the first 6 months, and essentially we progressed into the second part of the program very, very quickly when we did this trial. And essentially what the results show that we were seeing depletion of the CLL cells at 6 months time point, and we also found out that the bone marrow responses were taking longer. So we were looking at all of those things at the same time. But then the next step was what to do next with these patients. And we then amended the trial and allowed two arms to go into this study. One was obviously the ibrutinib monotherapy arm, which was continuing the therapy. And we saw that there is depletion of CLL cells over a number of months. And you can see on the x-axis going up to 6 years, there was 2.6 log reduction. But when we gave patients who were in the relapsed refractory cohort of obinutuzumab, these are 30 patients, and what we found was that if you have given somebody ibrutinib for a year and then we give obinutuzumab, you get massive depletion, 4 log reduction in their CLL count, which is different to when we use the combination. So even by doing a simple thing, we were able to do some correlative work between the two cohorts of the study. And this gave us a very good idea that actually consolidation in this kind of setting may work. And at the same time, we were doing another trial, which was the obinutuzumab consolidation, and this is called the Galactic trial. And these are the patients who were treated with chemoimmunotherapy, FCR based therapy. And some of these patients had MRD positivity at the end of the treatment, which we do see in about 70% of FCR treated patients in the bone marrow, about 50% in the peripheral blood. And what we found was that if we gave obinutuzumab to these patients, you can clearly see that there was difference between the outcomes in the two arms of the study. So these blue curves are the patients who did not receive obinutuzumab, whereas the patients who received obinutuzumab, there was a major difference between the two. So this was going alongside the Icicle extension study that I was telling you earlier. And the things were changing at that time, and we had another drug by the time we finished the Icicle extension. That was around 2016, but we had another new kid on the block, which was venetoclax. So venetoclax was a BCL2 inhibitor. And we used, instead of using obinutuzumab, we thought that we used combination of ibrutinib with venetoclax. And the concept was that ibrutinib will mobilize the cells, and then venetoclax will actually kill the cells. And this is the schema of the study that we used. We gave everybody ibrutinib for first 2 months and then added venetoclax. And then here we used the concept of defining therapy based on response to individual patients. So people who became MRD negative, which means that we couldn't pick up 1 in 10,000 leukocytes, a CLL cell. They got 12 more months of therapy, 6 more months of therapy, so 14 months in total. If the patients became MRD negative at the combination of 12 months, they got 18 months of therapy, and some patients went on to, month 14 went on to receive 12 more months of therapy, so they had 26 months of therapy, and then there are a few patients who went on to have 3 years of therapy. So this was again a small trial, 50 patients, and that allowed us to use this concept to be established. And what we found in this study was that the outcomes were very good, and the majority of the patients did extremely well with this combination. And that's what you're trying to get out of a phase 2 study, that essentially the combination is safe. And secondly, this could be taken forward into another study. And you can see the estimates that I wouldn't dwell into that too much. But what we also found out that the main benefit that we're seeing the combination was at month 8, month 12, and then some patients continue to have a response by month 24. So again, we found that if you have very good depletion of MRD in the first 2 months of combination, those were the patients who actually did the best in this trial. So again, this trial allowed us to use this concept and give us correlative biology to take it forward. And this is essentially how we incorporated this phase 2 program into the phase 3 trial. So this is the FLAIR study, and initially in 2014, we still had FCR as the standard of therapy. And we compared that to ibrutinib and rituximab. So you can see number of patients there, 377 patients in each arm of the study. But what happened at the same time was that we were using Icicle trial as in the relapse refractory cohort, which was the ibrutinib monotherapy. In 2016, we added the obinutuzumab, and then we also started the ibrutinib with venetoclax study in the Clarity trial. And essentially by 2017, it was very clear based on not only our data, but other trials, ECOG 1912, is that ibrutinib rituximab was superior as compared to FCR. Now, if you wanted to just keep on going with the study, I don't think at the moment that would have made any major impact, but we decided that we need to adapt the trial. And we already had the standard arm there, which was the FCR patients. And we incorporated two other arms. One was the ibrutinib only arm because other data from MD Anderson and few other researchers was showing us that rituximab addition to ibrutinib was not really a good thing, and it's not adding much to that. But then we also incorporated the ibrutinib with venetoclax arm based on the data that we were seeing from Clarity study. And those formed our 3 experimental arms of the study. And essentially, we were able to recruit patients into both of the studies, and you can see some of this recruitment went into COVID pandemic. And we were planning to do further correlative studies and trying to come up with the next program, which was just named as FLAIR-2. And as a result of this, now we have presented quite a lot of data, which is in the phase 3 study. So this is the ibrutinib and rituximab data as compared to FCR. This was 771 patients. So that's the first part of the FLAIR study. And essentially, we were wanted to see whether primary endpoint, which is ibrutinib rituximab, was superior as compared to FCR in terms of PFS. And really, in terms of the outcomes, we're coming up to nearly a follow-up of around 4 years, and this data will be updated very soon this year. And we did show that ibrutinib rituximab was superior as compared to FCR, but there was no overall survival advantage. And that was dissimilar to what ECOG 1912 was showing, where ibrutinib rituximab had an overall survival advantage. And the main reason for that was that a lot of our patients in the FCR arm did receive a targeted drugs, which was different. And one of the other things was that we are very good at giving FCR to our patients in the FLAIR trial because our outcomes were excellent as compared to the old FCR trials that we did many years ago. Well, one thing we were able to pick up on this study was that patients who were receiving ibrutinib rituximab had a higher risk of sudden unexplained death or cardiac death. And this was, I think it's fair to say nearly every clinician who dealt with CLL was kind of aware of it. But I think in terms of a bigger clinical trial, we reported it. And then we did a meta-analysis to look at what are the other trials showing, and actually nearly all the trials were showing the same thing. It's just that it wasn't being reported because the numbers were very small. And as a result of that, this led to us presenting this data, which obviously didn't come as a surprise to a lot of people, but did make an impact that we are actually looking at the toxicity question in a large phase 3 study as well. But I think one of the main questions really in CLL has been that whether we are able to functionally cure some of these patients. This is actually the basis of the FLAIR study with the I+V arm. And what we want to see is this curve, which is the log resistant disease. So on your y-axis is the log of resistant disease, and then the probability density. And this you can make this for any tumor really. And with CLL, what you will find is that there would be some number of patients who will be cured, and then there will be some patients who will fall into this middle curve, where essentially these patients will be destined to relapse. And then on the top is a clinically detectable disease. And we want to move most patients into this in the cured category. And in terms of the design of the study, we included these two arms. And the primary endpoint, we were looking at ibrutinib-ven versus ibrutinib. And we chose MRD as an endpoint, and that we can talk about that because that was a bit irrelevant to look at that question, but actually was able to give us an early answer in this study. And in terms of the other endpoints, we were looking at the PFS, and we've shown data for FCR versus I+V, which I will show. And then there are other endpoints. In one trial with the adaptive design, we are able to answer multiple questions, which if I was going to do multiple trials, this would have taken us ages to do those trials, and we would not be able to incorporate all of those questions. And there are some other additional phase 2 randomization that we're looking at. So this is the trial that we presented at ASH, FCR versus I+V. So if you remember that one arm, this was 3-arm study now, FCR versus ibrutinib versus I+V. And these are the stopping rules that we used, and they are very similar to Clarity stopping rules, but the duration of therapy is increased. Patients getting MRD negative at 1 year gets 2 years of therapy, and then the patients getting 2 years of therapy, 2 years of MRD negativity gets 4 years of therapy, and then 6 years is the final bit. But there are 18 patients who became MRD negative at 18 months get 3 years of therapy. And essentially what we found was that with such a short follow-up, we saw a PFS advantage in favor of I+V, but also an overall survival advantage, which is quite difficult to see actually in a phase 3 study, even when you have got chemoimmunotherapy arm as your standard of therapy. And what we were able to see is that if you reduce the TLS risk of your patient, and with patients with unmutated IGHV, these patients respond better to MRD-driven I+V. This is the data I updated at ASH this year. And then we were able to say that nearly half of the patients just need 2 years of therapy, nearly 60% of the patients needed 3 years of therapy, and 7 out of 10 patients needed 4 years of therapy. So not every patient was needing full 6 years of therapy. And the main patients who were benefiting from this was the unmutated patients, where also we were able to say now, based on other studies, that we are over-treating some of the IGHV mutated patients as well. And one of the important thing is the durability of the response, whether we were able to show that giving I+V in this way, whether everybody is relapsing at the MRD level. And there are very few patients who have relapsed. So that's about 13 patients. And most of those patients had IGHV unmutated disease, which is not surprising because that's the more proliferative CLL that we see. So this data is being updated, and pleased to say that we hopefully will be getting some more data out at EHA, looking at further questions, which would be an interesting data to look at. And the other thing we presented was that the adverse events mainly happen in the first 2 years of therapy, and from there on, the patients are tolerating the treatment very well. One of the main things was that there was more secondary malignancies in the FCR arm as compared to the I+V arm, and that we were also able to share this with our colleagues. But I think one of the important issues really in the real practice now is that a lot of patients will get continuous therapy, and this is just some data showing that patients who are relapsing on ibrutinib have developed a point mutation, and that's pretty much true for other BTK inhibitors as well. And that led us to construct another trial, the static trial. And the main concept really there was that when it's primarily based on prostate cancer and some breast cancer studies, that if you have got a clone with sensitive cells, which are these purple cells, and then you've got the resistant cell in between there, if you keep on giving them the drug pressure, the resistance clone would come out. Whereas if you give them evolution-based therapy, that is intermittent strategy, what you find is that you never will lose out with a sensitive cell. So the resistant cells may increase, but actually you can increase the response of therapy. And what we also found from FLAIR study was that there were 98 patients who stopped after 6 years of ibrutinib rituximab. And those patients, we were not able to get them the static trial open in time. And we just monitored them, their peripheral blood MRD, and majority of those patients, their MRD change was only 0.02 log change over the first year after ibrutinib cessation. So it primarily tells us that actually not everybody will relapse when they stop a BTK inhibitor. And that's took us to making this trial, the static study. This is intermittent versus continuous treatment strategy. We want to look at essentially half of the patients will receive continuous therapy until disease progression, so no change. And the other half who have achieved very good deep response with single agent BTKI, they would be able to stop therapy. But if they progress based on blood criteria or clinical criteria, they're able to restart. And if they go into remission again, they will be able to stop therapy as well. And the primary endpoint is the treatment strategy failure, which is the intermittent treatment strategy. So this trial is now open for recruitment in UK, and I think for all the continuous therapy patients, I think this would be a very good trial because we will do it in a controlled manner in this study, and it will give us an important answer. So there are frontline patients who can go into the study coming out from FLAIR, and then there are patients who are previously treated, and hopefully we will be able to include the other BTKI inhibitors in that space as well, but we're waiting for some approvals to come through. And I think lastly, what I would say about trials is that it's a very kind of open space at this moment in time, and you have to not only look at UK, you have to look at other groups who are doing very important trials, and you have to learn from them because essentially that's how you take the field forward. So in clinical trials in CLL, that's one of the major things. So with our trial, FLAIR, I've already shown you some data. There's CLL 18 trial, which is hopefully will be recruiting very soon. The venetoclax obinutuzumab is the control arm. And then you've got venetoclax with pirtobrutinib, and then there is MRD-driven Ven/Perto. Then we have already seen data for acalabrutinib with venetoclax, that acalabrutinib with venetoclax plus minus obinutuzumab. And that trial was published, it was presented at ASH 2024. There is a MAGIC trial, which is an academic trial being done in the US, where venetoclax obinutuzumab has been compared to acalabrutinib venetoclax, and it's also partly MRD driven, so patients who are MRD positive can continue and also in the acala arm with PFS as an endpoint. Celestial is looking at venetoclax obinutuzumab versus zanubrutinib and sonrotoclax. CLL 17, a very important trial looking at ibrutinib, venetoclax obinutuzumab, or I+V. So these are all standard treatments, and PFS is the primary endpoint of this study. And then I've talked about static as well. So you can see it's a very kind of dynamic space where you need to look at the questions that are unanswered at the moment, but the frontline space is always going to be crowded. There is going to be a lot of space in the relapse refractory space, and the next trials that we are doing are going to be looking at these combinations. So we propose to consider MRD-driven combination, and we are working alongside teams to look at in the Celestial trial. We also are looking at an area of unmet need where nearly a third of CLL patients who do not need therapy. But we know that patients who start getting infections, their overall survival is poor as compared to people who don't get infections. So there is this important question whether if we debulk their disease, whether we reduce the risk of waning immunity in CLL, and we hope we can work on that. And then we are trying to incorporate the concept that we started in Clarity and Flare, is whether we can individualize therapy for relapsed refractory CLL further. And there are some trials in that space. And lastly, but not least, we can't do it on our own. I think we need to collaborate with other academic CLL group, and essentially all people who are on this call. Yeah, we need young CLL researchers, young nurses who need to be part of this strategy, because that's how we would be able to follow the science further. And lastly, the most important thing really is when we are constructing these trials, the most important thing is the patient voice in all of this, because I can make a trial and try to answer a question which is sticking in my head, but if it's not important to the patients, then it's not going to further their improving outcomes that we want to achieve. So I think the patient voice is the most important thing. Whenever there is a new trial strategy that's going to go forward, it needs a patient voice, without which we wouldn't be able to get the trials through our funders. And I think this is my last slide. So I think well-designed trial programs are critical to moving towards cure. That's one of our strategy in UK, and we're hoping we have made some progress in that. I think for our program, we have tried to show that MRD eradication is required for durable treatment-free period for some patients and possibly cure. I think the combinations are very successful in this space, and it's showing great promise at this moment in time. And I think I've given you a flavor of what is coming your way in the next coming few years, and we will be looking out for these trials. And I think I will stop the talk where I started from, that the standard of care is now moving again, so the trials will have to catch up with the change again. No, just acknowledging all the patients really, and colleagues who participated in all of these trials. This is not an effort from one team, but especially HMDS and University of Leeds, who've helped us to design all of these trials and do all the hard work, and also the NCRI CLL subgroup, because we can't recruit patients unless we've got focus of our colleagues to help us to recruit these patients. So thank you to all.
So Tal, so many things to talk about around trials, trial design. Let's dive in first with MRD, because MRD is that hot potato which is discussed by everyone designing trials, and all academics. We all roll in or like the discussion about MRD. But I guess regulators, I know there has been movement in the last few years with regulators, but the pharmaceutical industry, we have to be honest, have always been nervous about MRD, because the majority of community physicians internationally who are treating CLL, will they engage with MRD? And I guess that's one of the biggest problems, isn't it? If we truly want to get the best outcomes, because I think we all have to agree the FLAIR trial with an MRD-guided strategy is the best treatment outcomes that CLL patients have ever had. How do we work that into routine practice? Do you have any thought on that to translate that?
That's a fantastic question. I think the issue it has been is to convince people that it's the right approach to take for patients. And we are, if you were a CML doctor, you will be very much used to MRD and monitoring patients MRD very closely, and now switching therapy. In the CLL space, it's difficult because we've got fantastic treatments, and now the question has moved on to whether we can give treatment-free intervals to our patients and then retreat patients, and that's the kind of mantra that's going on. But if you are a pure researcher looking at the different cross-trial comparisons, which I know we shouldn't be doing, but that's the reality we will end up doing. I think if you have a patient who has got unmutated IGHV and you want to give them the best therapy, the data shows that the MRD-driven therapy is probably the right approach. Now, in order for this to be applicable, we need to be able to do MRD in normal setting. The second thing, it needs to be cost effective. And the third thing really is that we don't cause too much toxicity. And I think FLAIR does help us to give us some long-term data on this. So we will be assessing MRD for 10 years in our patients, and sometimes we forget that the longer the trial data is accumulated for, that's the strongest point of the trial, but people forget about a trial. And I think that's going to be a very important resource, that we would be able to say that at 10 years, if somebody had MRD-driven I+V and they're not needed any further therapy, it's probably a very strong argument, actually, that we should be using that strategy.
So let me push back just slightly, because I've just got to air the cynical voice that I heard at ASH floating around, because we know from the biology of CLL that these unmutated patients, they go into a deep remission faster, and then they pop out of this remission faster. And so I heard Americans telling me, well, FLAIR obviously works because you're simply giving more of the drugs. And if you were the cynic, you could potentially turn around and said, look, I+V, it's just the pharma companies have got it wrong. It shouldn't be 15 months. Everyone should just have 3 years of I+V. Yeah, you're going to overtreat some, but your overall population benefit is good enough to just justify the treatment. How would you push back on that argument?
I think there is some truth to that, just to make it easier, but I would push back on that to say that once you go down to the realms of 10⁻⁵ or 10⁻⁶ MRD level, below that there is a delta which is pretty wide, and I think some of that delta I've tried to show you in the graphs is that there are some patients who will progress no matter how much long we give I+V for, but there are some patients who might be about 30 to 40% of unmutated IGHV patients who might not need another therapy, and they might be cured of the disease. And what FLAIR does is give opportunity to that patients that we reach that point. But if we don't look at that question, we're never going to answer that question. And I think giving everybody 3 years, or what we found out really also is that when we're doing the same thing for mutated IGHV patients, we're doing the wrong thing. We're probably overtreating some of our patients. So I think in all honesty, this debate is going to go on for some time, and I think we're going to have heated discussions in our meetings. But at the end of the day, if this was a completely rubbish statement to make, then the Germans won't be doing the MRD-driven PERT-01 trial. MAGIC trial is looking at MRD-driven therapy. People are trying to look at clonoSEQ. So I think everybody's trying to use the concept in one way or another. But I think our way is the more proactive way of managing this.
So that's great. So I'm just going to go to the Q&A to make sure we're just covering off some of these. There's some good educational points. So thank you. One question directly on MRD. Lots of discussion about it in trials. Do we mean marrow or blood? So a quick educational point, Tal, on blood versus marrow MRD and different treatments.
So when OB, yes, definitely marrow. If you're looking at I+V, blood is as good as bone marrow, only 0.2 log difference between marrow and peripheral blood.
So it does depend a little bit on treatments, but I think in this context, and it's just nicer for the patient, isn't it? Let's do it on the peripheral blood. Then another quick educational question, perhaps I'll just cover. In relapse, is CLL associated with cytogenetic change and evolution? And I guess that's one of these fundamental principles of CLL, that as it cycles through lines of therapy, it can evolve genetically with collections of mutations, that either mutations that stop the drug from using, and also broader mutations that associate with more proliferative clones and general resistance, PP53 mutations, etc. Now, I haven't missed this question about obinutuzumab in second line. I am going to come on to that with trial design, Tal. But quickly, John and Lelia. John, let me pick on you first. The trial design, the UK really has had an exciting forefront, and you've confessed previously, the two of you, that you've perhaps been on some of these early trials. From a patient viewpoint, is that something that inspires patients in CLL/SA?
Yeah, certainly, George, and the complexity and depth of the landscape that Tal articulated there, is from a simple patient's perspective, is really difficult to navigate. So in explaining all of the aspects and outcomes of trials to patients, the clinician really needs to take time to go through that, because there are so many spinning plates that patients do find it difficult to keep up. And we're not knocking it. It's great that there's so many trials on, and Lelia as part of the flare management group is great as well.
So go on, John. Then Lelia, you get the difficult question. So how do you explain to your patients that we've shown a prospective trial that has the best survivors in CLL, and we can't give it to our patients off a trial?
Well, I don't think you can, is the simple answer, George. But I think it absolutely underlines the importance of what Tal was saying, of having early engagement with the patient community, so that you begin to have those conversations early on. I think most people who signed the consent form with Flare probably never realised that that was going to be a problem. And actually, if you ask people why they take part in trials, most people have a strong factor. Sure, we all think we'll get good care, but a strong factor is altruism. People want to find answers to the question, to the ideal treatments for what they've got. So I think it's a really good case study almost of where the earlier you start those conversations with patient groups and with individual people, the more you might find some answers. And I think, just what you were discussing earlier about the dilemmas of choices and different regimens of where does MID fit, and fixed regimens versus long-term treatments and how long the fix could be. Those are fantastic conversations to have with a range of different, because everyone had lots of, there isn't one view in the CLL community. There's a range.
Lelia, are you getting your patients contacting you saying, look, I'm on I+V, I'm at my 12th month, and I've read this thing called the FLARE trial, and how can I tell my doctor I want to carry on?
I'm not fielding those kind of questions. That's not my role within CLL support. I have been asked to talk to people, actually through my role in leukemia care as a CLL buddy. I have been asked to talk to people who are thinking about going into FLARE, who were presented with this was a while ago, presented with the participant information sheet. And one woman, I spent 2 hours answering her questions. And I don't know whether she decided to go into the study or not, but she had some very good questions. And she clearly read most of the 30+ page leaflet.
Wow, good stuff. Hal, your hand was raised. Thank you, Lelia. Hal.
Yeah, no, I think it's a difficult one, but really it's a job for us as researchers to take the study results forward and try to convince our regulators here. And all I can say is that we are working towards that and trying to make a case that when we need to remember, when we constructed the trial, we didn't know that these results would be as good as what they are. And at the same time, the world moved on to fixed duration therapy. And I take your point about, is 15 months the right duration of therapy for I+V? In my view, no. But that's where we are at the moment, and the pharma world found it quite much easier to get label based on I+V for 15 months. But we are trying to make a case that if you give longer duration of therapy, that would be cost effective to NHS for a longer period of time. And I think that's the only way we were going to get the approvals here. So there is work happening at the backdrop, but we are going to be seeing some very interesting results tomorrow, actually, for some updated data. And we might be able to share that with our colleagues at EHA. And if we are able to see the 6 years follow-ups on this and the results look as good as what we've seen before, then it makes a very strong argument to take it forward, and people who control the budgets to take notice.
Wow, no, you heard it here. You heard it here. That with more data's coming. Piers, you better pay attention, because I'm going to be dragging you in very soon on this question. Because what the question in the chat, the Q&A, why do we only have obinutuzumab first line? Tal, I love that data that you show, that very thought-provoking. Introducing obinutuzumab later can actually push the depth of your remission down quite significantly. But it's a question that comes up a lot in MDT discussions, and we've talked about it with Renata over the last couple of weeks, that actually you've got obinutuzumab you can use first line, but with current pathways, we can't use that antibody second line. And this question is, are there no trials looking at depth in second line? So Tal, can I get you to comment first on that fascinating observation that obinutuzumab actually is consolidation? It might be the best way to use that antibody. And then Piers, I'm going to drag you in to get your thoughts on trial design in the relapse setting and what is the role of obinutuzumab.
The simple answer, George, is that yes, we have used consolidation trials for a long time in UK. So if somebody can remember, Campat treated patients in consolidation. So that was a successful trial, but came with toxicity. Galactic basically showed the same thing, but the problem was with the trial was that the ibrutinib was the hero at that point, and nobody wanted to recruit in that study. But and in the relapse setting, there is a trial that is now going to be using obinutuzumab, and that trial would be hopefully recruiting next year. And if that trial is successful, we may be able to use obinutuzumab in the relapse space as well.
So Piers, I'll make your question a bit softer. In the relapse setting, it is challenging, isn't it? Because people are coming in from these different therapies. So is it going to be straightforward with this constantly changing landscape to get a catch-all trial, going to throw in the antibodies, BTKs, et cetera, What are your thoughts on trial design in the relapse setting?
I think it's quite difficult, as you say, because everyone's going to get very different routes. I mean, now we're going to get likely to get another regime, the acalabrutinib regime, aren't we? Later this year, I think. That will almost certainly get licensed and may get funding. So you're going to have 5 or 6 ways to get to whatever point, and where are you going to take these patients into a relapse trial? I think you're probably going to take a standard progression for, that someone who's progressed under standard criteria would be eligible, and it wouldn't probably matter how they've gone there. What you're going to use, I'm not entirely sure, particularly if we're going to continue to use very effective agents up front. So it's probably going to be for patients who sort of early relapsing and late relapsing would be the way I would think about it. And your early relapses, particularly if you've seen your effective agents early, you might be looking at novel therapies there for your relapse therapy. I think Tal's design of adding in a bispecific to a backbone, which we already know works very well, is very nice in the PRECISE study. Late relapses, I think almost certainly you're going to want to use for similar agents to what you used up front. Maybe, as we were alluding to earlier, you want them for longer or slightly different combinations or with different endpoints. And it would be very nice to have probably the more effective antibody there. It seems odd in my mind that currently we use obinutuzumab frontline, but I think most of us who are CLL familiar with treating CLL, obinutuzumab is a very effective antibody, whereas my general view about rituximab in combination with either BTKI or with a BCL2 inhibitor, it doesn't actually add that much. And I'm pretty relaxed really when, for instance, giving VR, whether you get all the R or where it is in the relapse setting. I don't think I'd feel the same way about obinutuzumab at all.
Yeah, no, that's quite a good educational point, isn't it? To flag to people who are listening, getting more educational value, that Tal touched on this, that rituximab combining with ibrutinib probably doesn't really add a huge amount. But obinutuzumab does seem to be different. I think as a reflection, Piers, to play devil's advocate, when we think obinutuzumab, we all saw quite a bit of significant immunosuppression, and we've had problems with COVID. And those triplets, we're all looking at the triplet trials up front with half an eye on toxicity as much as efficacy. And it always makes me think that one of the problems we all see in our clinics, and I'm sure the patients would support this, is this gradual immune failure, that the more lines of therapy, our patients picking up infections. And it's always been with me about obinutuzumab, highly effective in CLL, but if you're throwing it in second line, third line, is the infection consequence of that going to balance the equation too far?
I agree with you, George, and I certainly agree about triplets. I think triplets will be for the very few. I think there will be the highly selected patients, and we don't know who they are really. I mean, we've all probably got our hunch in clinic who we would think about it for, but I definitely think you would think very much about toxicity, and I agree with the comment that perhaps obinutuzumab is more effective. But do you actually need it? I mean, actually, for the vast majority of patients, we're probably doing extremely well with 2 classes of drug already. And for the vast majority of patients, even if they relapse, you're probably going to be able to use that combination in some form or other again. So we might be overly worried. And there's always going to be a few patients, so those primary refractory patients or those highly genomically, who are going to need probably something quite different. But actually, for the vast majority of CLL patients, I think that balance between toxicity and efficacy is absolutely essential, where we should be looking at.
Now then, so I'm going to finish off this section by going for a more controversial. So I think Renata and John, I'll pick on you, and Helen and Nick, I might drag you in. Early stage CLL. Tal touched on this point. We don't treat well people with early stage CLL, but how about those with immune failure? And it is a fascinating topic. We've got drugs that are well tolerated. We have CLL patients clinically who are simply a bit ill with their CLL, and that progressive immune failure, which some unfortunate patients are dealt that difficult hand. And I was enthused seeing that with Tal. Could we intervene with these patients early? So Renata, chair of the UK guidelines, we'd be the brave CLL group, wouldn't we, to start advocating treatment at the moment up front for early stage CLL? That's just a no-go, isn't it? The well patient.
No, definitely no-go. But I think horizon is changing, because obviously we've got this Prevent Call, which is run in Denmark by Carsten Niemann, and he's using this quite a complex mathematical model, identify those patients who, as per IWCLL, normally would not need it. Treatment. Obviously, they're high risk for infection. And actually, there was a poster in latest ASH updating just first patient who were treated with very short course of venetoclax acalabrutinib for those high risk patients with infection. Now, they only did in vitro data, so we don't have information whether actually rates of infection has been reduced. But I think watch this space as this trial evolves. So because you're right, I mean, sometimes we can see those patients just falling down, and obviously each infection is just this dip on the survival curve, and each infection compromises that patient, and we can't stop it. Even with the best preventative way, even with Paxlovid being available, Tamiflu, vaccinations, you still, and obviously the double pneumococcal vaccination, you can't stop it. So maybe what Carsten Niemann and team are doing, maybe that's the one way to go, and was a few other data. Again, you know, obviously Carsten Newman showed, I think there was a British Journal for Cancer about 10 years ago, that we have improved patient survival overall, but we have not improved their survival for infections, which was quite telling. And also there was some data from Jennifer Brown group trying to challenge CLL IPI in targeted therapies. And there was an oral presentation at ASH. I think it was Azovero who presented the data. And it's again, interestingly, that high-risk patients, the highest reason for death was infections. So obviously,
and that's something we as clinicians managing CLL are acutely aware of. So I'm going to keep it moving a bit, Renata, just to get everybody in. Yeah. So John, you're talking to your fellow patients and you say, well, the docs just I'm getting all these infections. He wants to consent me into a trial to give me 2 different drugs, and the prime side effect of both of them seems to be infections. This sounds crazy. How are we going to sell that one to patients? Do you think they would buy it as a trial?
I think it's a very difficult sell, to be honest with you. However, the patient is going through their active monitoring, and we're using that term now. And from a patient perspective who's getting more infections, if we say that we're looking after you by trying to manage your infections, we're trying to hold off on treatment for as long as is necessary. And I actually wrote that point down when Tal mentioned it about the infection risk, before treatment was necessary. And I do think it's a hard sell to patients to tell them we're going to put you into a trial which may make your immune system even more compromised, because in their day-to-day life, that's what's affecting them. It's their, the quality of life is significantly affected by constant infections, respiratory infections, sinus infections. It really is a hard one to sell, George.
But it's actually, John, I made a promise to a patient who did the usual, came into the clinic last week. He said, can we stop using watch and wait? I've come up with another one called monitor and manage. I thought, ooh, monitor and manage. So I promised them I'd feed it back next Monday. Monitor and manage, although I was going to send them back to their GP, so maybe monitor and GP manage. Oh no, sorry, yeah. Monitor and manage.
As long as we give them the impression we're looking after them at different frequencies, then that's the main message. As long as we don't use the W and W, that's fine.
Oh, I don't know, out of the window. Now, Helen and Nick, I'm going to just get your final comments before we hand over to Renata to chair the second session. Helen, have you noticed an increase in the number of patients asking for treatment in the early stage CLL, or do you think still with robust counselling you can keep patients on the monitor and manage, whatever it is, even if they're pushing?
Yeah, I'm not sure I've noticed an increase in patients asking for treatment, asymptomatic patients. I always remember Lelia talking about patients talking about their symptoms and how us as doctors might tend to write a letter saying the patient is asymptomatic, and the patient may not feel asymptomatic. It just might be that their symptoms don't meet our criteria for treatment, and how important it is to acknowledge that. But I'm usually, I hope, able to counsel patients if I think that the symptoms that they're telling me aren't going to be helped by giving them CLL treatment and might actually make some symptoms worse. I think that usually with counselling, we're able to sort of get on the same page about that. I think it's really interesting, though, the question about whether we should be or whether we can treat patients because of their immune problems and infection problems. I think that's really interesting.
Nick, just a final comment, using our fellow specialists like immunologists, and I think the challenge you have with that progressive immune failure, isn't it, in the clinic is quite a real one. Are you referring over to immunology for their input, all of their strategies, or are you tending to manage them in your clinic?
I take interest in the immune side of things, and I'm quite involved with the immunoglobulin panel at my trust, so I tend to try to manage that on my own. But it also depends on how the immunologists you've got to hand and how proactive and how active they are regarding to the specific subject of secondary immune deficiency. We are actually going to this is one of the needs of the management of CLL patients clearly, and we're in process of trying to get some guidance out there to try to identify early and investigate these patients who we think who are having immune failure related to the CLL, to raise awareness, to get people to think about immunoglobulin replacements as and when needed, to think about sending the patients to immunology if you've got a reliable immunologist to hand, and also to perhaps think about disease related immune dysfunction and whether or not that can make you treat patients slightly earlier, perhaps, that we traditionally used to, which is something that has been changing. And to your point earlier on, I think I have been more aware of that over the last few years, treating patients slightly earlier because you see the infections coming, but also quite significantly with fatigue. I think that we tend to dismiss fatigue quite a lot, and quite recently I've treated at least a couple of patients that come to clinic saying, look, I'm just really exhausted, and it is a WCLL criteria, a bit soft to most clinicians traditionally, but ever since we've done some observational studies, I'm kind of more sensitive and more kind of acting proactively against it, because I think it really demises people's quality of life.
Yeah, and I think that is a very good point there, Nick, because I've become aware of that. If you're second half of 70s, I mean, what are you saving yourself for? And if you're fatigued, being dragged down a bit by your CLL, it's not so bad. You know that patient is not going to die from their CLL in the next year or two, but actually you can just give them some BTKI tablets and their actual quality of life improves. So, and I think that is entirely a reasonable thing to do. So, Tal, last comments on clinical trials and any observations?
Wanted to just come back to the point John was making, that it's hard sell, and I think it is a hard sell in terms of the concept, but that's where you need data. I think the data is there. There is Australian registry, Danish registry to tell us that actually we are not doing very well with this group of patients. The second thing is that we've collected a lot of data from HMRN to say that patients who are getting a lot of infections, there is a lot of B cell depletion, and plasma cells in those patients are reducing over time. So there is science behind it to ask the question. And if we ask the question in a way which is understandable for the patients why we are doing this, then you will have insights from people like John and Lelia to tell us how to sell the trial. But I think it's an important question that needs to be answered, and hopefully we will be able to get some answers for our patients, so that we're not seeing everybody with secondary immunodeficiency in second line, and we might be able to give them a obinutuzumab then.
An excellent point to finish on. So, Renata, I'm handing over to you, finalist. Tal, thank you ever so much. An amazing talk and brilliant discussion. And thank you to my fellow panel members.